My name is Len Kunka. I'm a partner at the law firm of Thomson Rogers, and it's my pleasure to introduce our next speaker, Dr. Chanth Seyone. And I'm sure that Dr. Seyone is very well known to many of you in the audience. But for those of you who don't know Dr. Seyone, Dr. Seyone's a neuropsychiatrist, fellow of the Royal College, who has done his fellowship in neuropsychiatry, sleep medicine, and community psychiatry. He is the founding director of the Acquired Brain Injury Clinic at Toronto Western Hospital, which, as most of you know, is a clinic that assesses and manages patients with acquired brain injury, and they continue to follow their patients following their assessment and initial treatment. He's on the academic faculty at the University of Toronto. He teaches all levels, as I understand, from students through to doctors and allied healthcare professionals. He acts as a consultant for a number of community-based head injury associations, for lawyers, for insurance companies. He pretty much does it all. I don't know where he finds the time to do all of the things that he does. He's very active. He's well known as well for his research and his publications, and you may know that one of his workshops, which was entitled A Roadmap to Acquired Brain Injury, won the prestigious Ivan Silver Award for Excellence in Mental Health Education. So it's my pleasure to introduce to you Dr. Chanth Seyone.
Thank you very much. Thank you. Time is always a bit of an issue. I often don't know where I find the time, but I think one of the problems is that my wife always complains that I'm spending too much time at hospital, so that might be a bit of an issue at some point in time. The latest is that we got a puppy, so that's actually going to create even more of a problem. My younger daughter kind of convinced us over a period of about 7 years that we need to get a puppy, and we got a puppy about 3 weeks ago, 12 weeks old, and that's kind of making me do all the things that I haven't kind of done in a number of years, considering that my daughters are now teenagers. So I'm kind of having gates back in my house and everything else, and that's actually kind of feeling more like a prisoner at home than anything else. So I think I probably will spend more time at home, at work rather. Okay, I was asked to talk about psychopharmacological management of brain injuries. Now, when I was actually trying to think about what I was going to talk about, this is a vast field, and if I actually kind of just dish out medications and tell you about side effects and that this medication is used for depression, this medication is used for anxiety, this medication is used for psychosis, it's going to be the most boring talk you can imagine, right? All of you will fall asleep, and all of you will essentially fall asleep, and I think lunch will be a lot earlier than what we planned. So I tried to kind of put some context into why you do certain things. If I can get this to work. So what I'm going to try and do is talk a little bit about ABI itself. What is ABI? How actually kind of what part of the brain gets damaged, and then try and put why we do medications and what medications into some sort of a context. I'm going to try and enumerate some of the psychopathies that happen after a brain injury, and then discuss management with medications. Now, as everybody knows, ABI is dynamic. Now, what do I mean by dynamic? That it changes. No person who has a brain injury, in my experience, is static. So they don't have a brain injury, they have a certain number of deficits soon after the brain injury, and they remain with those deficits for the rest of their life. The deficits keep changing depending on what the person's family situation is, what the environment is, and therefore the needs of this particular patient for various types of treatment also keeps changing. And also it's multidimensional, so you can actually get focal injuries. If somebody actually hits you on the head with a hammer, or you get diffuse axonal injuries, which become more of a problem because you get more areas of the brain damaged. You get microvascular injury, which is something that happens even after the initial injury. You get kind of vascular damage, which then leads to further injury. You get neuronal excitotoxic loss. You get hypoxic ischemic injuries. Patients who have cardiac arrests, for example, and they end up not having any oxygen for about 6 minutes, 7 minutes, they end up with hypoxemia or anoxic encephalopathies. That causes its own level of brain injuries. Everybody knows about coup contra coup injuries. Now, why did I put this picture up? Because in most of these injuries, one of the main areas of damage is the front part of the brain, the frontal lobe. And sorry, I should actually mention, I made some minor changes to my slides. Now, the problem that happens in some of these talks is that they want the slides about a week or 2 weeks ahead. I'm never ready that early, right? So I actually rushed through, kind of prepared a certain number of slides, and then I was looking through the slides this week and realized that maybe adding a few other slides might be actually helpful. So most of the slides are the same. There's a few extra slides added to it, so just to kind of confuse things a little bit further. So this is one of the extra slides. So as you can see in this picture, there is more kind of damage to the front part of the brain because the brain basically bounces inside our skulls. And when it starts bouncing inside our skulls, you end up with frontal lobe damage. And most of the damage is actually in the orbitofrontal area, which is kind of just the inferior part of the frontal lobes as well. And this is a nice little picture I found, very simplistic, but basically tells you what the frontal lobe does. Frontal lobe is involved in judgment, in impulsivity, in how to think, not what they think about, but how to think. And these are the areas, if it's damaged, that patient can then end up with all sorts of psychopathologies, if you can imagine. Damaging the motor area leads to people becoming hemiplegic or paraplegic or whatever. But that is manageable. I mean, you end up with physical rehabilitation, and to some extent that's manageable. Whereas impulsivity isn't something that you actually see the day after the injury. You see it 6 months later, 6 years later, when patients tell you that this person just starts gambling, or this person is kind of having a meltdown because this person doesn't get a hot dog when the particular person wants. And these are the type of problems that people don't realize actually leads to significant difficulties in this person going into the community. If somebody is actually going out into the community and is now having a problem in the sidewalk, nobody wants to take this person out. But that is not considered a problem often because people don't really think of that as a problem. But that actually, in my opinion, creates more community problems and community reintegration problems than patients who have paraplegia. Paraplegia, everybody knows that you have paraplegia or hemiplegia. Everybody opens a door for you. But who opens a door because you're impulsive? Nobody does, right? So we are, as healthcare providers, to, in a sense, have to advocate for these patients and say, okay, we do need to open certain doors because these people do have problems with impulsivity, problems with judgment, problems with not knowing, not necessarily not knowing what to do, but how to do it. All right. Now, what are the psychiatric things that can happen after a brain injury? As this list shows, just about anything can happen. I actually tell my students that tell me in one word, what are the psychiatric problems that can happen in people with brain injuries? Any idea what that word is? All, or anything, right? Just about anything can happen. I mean, every psychiatric condition that you can think of can happen in somebody with a brain injury. The only thing that doesn't happen is pure schizophrenia. But having said that, patients who have a schizophrenic tendency or a premorbid predisposition to develop schizophrenia might develop early onset schizophrenia. They also, but even if they don't develop schizophrenia, they do actually often develop psychotic symptoms, which mimic schizophrenia. Now, the difference is, there are differences between the different types of psychotic symptoms that you get, and it's sometimes you have to be able to tease it out and say, no, this is actually not schizophrenia, this is actually psychosis as a result of a brain injury. So as this list shows, you get post-traumatic delirium, which happens soon after the injury. You get post-concussive syndromes. You get the maladaptive coping. You get cognitive difficulties, affective disorders, anxiety disorders, psychotic disorders, sleep disorders, personality disorders. What about the behavioral disorders, especially if people become very aggressive? What about effects on the family, effects on the community? So effective management has to address most of these factors at varying times. And also you have to realize that patients don't develop all of this bang at one time. They develop a lot of these things at varying times. So they may initially develop a little bit of post-concussive syndrome, which goes away after 6 months. Then they're fine for about 6 months after that because they are gung-ho about getting physiotherapy and getting kind of back to normal. They are gung-ho about saying, okay, I'm going to be able to get back to work in another 1 year because my physical limitations are going to be minimized. I'm getting a lot of speech therapy, I'm getting a lot of cognitive therapy. All of this is going to help me and I'm going to be fine. So they're fine for the next 6, 8 months or a year. Then they realize, no, they're not fine about a year later. They're still having difficulties. Maybe they try to go back to work. They find that they can't do the job that they were able to do before. they get fired, or they get laid off, or they get criticisms from their employers, that's when they start developing a sense of how bad their problems are. That's when they start maybe developing a little bit of depression. Starts off slowly, or they might get a little bit anxious. They kind of start, then what happens when they get a little bit anxious and depressed? They start becoming a little bit more antsy with the family. Maybe they don't have enough time for the children. Maybe they're getting more angry with their spouses. What happens? That leads to the family withdrawing from them. What happens then? He or she now notices that the family is not spending any time with that person, and he or she is being relegated to the corner of the room. What happens to the person's depression? Gets worse. So sometimes some of these psychopathologies actually you notice about a year or two later. You don't notice it 6 months into the injury. You don't notice it about a year into the injury. So sometimes I get requests from insurance companies or lawyers or whatever to tell me what happened. I mean, has this person reached maximal recovery or something a year after the injury? I said, I don't know. I don't know what's going to happen to this person, because I really don't know. This person may be fine a year after the injury, but all hell could break loose another 6 months later, and this person might need a hospitalization after that. So sometimes you just have to wait for a little while to see how this person actually kind of recovers from that injury. So what are the common issues? I'm going to talk only about a few issues that happen, and I'm actually going to be a little bit more technical here because I want to kind of emphasize to you that if there is biological damage, then the treatment has to be biological. A lot of people don't believe in medications. A lot of people think that medications are a little bit of fluff, and it's that we can manage the patient with behavioral therapy or cognitive therapy or the various other therapies. But if there is biological damage, if somebody is diabetic, you don't treat a diabetic person with cognitive behavior therapy. It's not going to help you. If the insulin is out of whack, you need to get the insulin back on track. The same way, if a depression is because there's left dorsolateral frontal and left basal ganglia damage, you repair the damage in some way, right? If there is acute post-ABI soon after or late onset, months to years depression, how do you deal with it? So if the acute is because there's a neurochemical imbalance or a neurophysiological imbalance with increased vegetative symptoms, this person needs medications at that time. Even late onset, there might be psychosocial problems at that time. But even that, you might need to give an antidepressant at some point in time to actually make this person feel better. Because otherwise, you're making your own job a lot more difficult. It's not the patient is obviously going to be the one who's suffering, but your job also gets so much more difficult because you're trying to provide all of this additional treatment in somebody who's not receptive to that treatment. Somebody who is basically just wants to be left alone, left in a corner because they're so depressed. But if you can't get them out of that corner, how do you actually provide the SLP or the physiotherapy or the occupational therapy or the back to work hardening or whatever you want to do, right? So that's where it becomes important to try and understand these patients. Patients who develop late onset depression often have somatic symptoms because they don't know how to tell you how distressed they are, so they actually end up having increased pain symptoms. They end up with gastrointestinal problems. They end up with significant headaches. So you then have to kind of figure out, okay, is this headache because the person is now having a neurological issue because they're going to increase intracranial pressure or whatever, or is it because the person might be very depressed, very anxious, but doesn't know how to tell the person or family member or whoever that they're very anxious and very depressed, and therefore now they are kind of developing worsening of symptoms. And somatic symptoms, as all of us know, do get worse when we are depressed or when we are sleep deprived. A lot of these patients develop significant sleep deprivation and significant sleep problems. So then if all of us party hard for about 3 days after that, I can almost guarantee all of us having more aches and pains and more, we feel horrible, we feel kind of mild headaches. Magnify that to somebody who hasn't actually slept properly for the last 3 months. And then kind of figure out what happens if they already have a headache because of the brain injury, now they're sleep deprived for 3 months, how bad their headache might be. And what is the treatment then? It's not actually treating the headache as much as treating the sleep problem, right? Anxiety disorders is usually associated with right hemispheric lesions, and it's generally presents as a generalized anxiety disorder, which is actually a difficult entity to really identify and kind of categorize. It's easy enough to diagnose somebody who is having panic attacks. Panic attacks, discrete periods of extreme anxiety, people kind of tell you that they're having that anxiety, they look as if they're anxiety. But if somebody is just extremely worried all the time, it's a little bit more difficult to kind of figure out at what level it actually becomes generalized anxiety disorder. And that's where sometimes the experience comes in and says, okay, no, this is more generalized anxiety disorder as opposed to increased anxiety. Because all of us get anxious. I mean, if I twist my ankle or something and it's not getting better, I'm actually a little bit anxious kind of 2 weeks into it and wondering what's going on with me. But I'm not having a generalized anxiety disorder. At what level does it become an anxiety disorder where I'm actually kind of not capable of getting past it without medications? What about bipolar affective disorder? It's again greater in right hemispheric lesions, especially affecting the basotemporal cortex or the limbic system. There is increased bipolar affective symptoms in patients who have developed epilepsy post-injury. And that's another thing. What happens in patients who actually develop epilepsy at the best of times? Let's assume there's no head injury at all, but the patient develops epilepsy. Epilepsy is a very disabling condition, not because of the fact that they have seizures, but because people don't know when they are going to have seizures. So what happens if you don't know what's going to happen to you? You tend to isolate yourself. You're scared of getting out in the community. You're scared of crossing the road because you might have a seizure. Somebody's taken your driving license away. That's going to make you even more isolated as well. So you end up spending more and more time at home, and that's why a lot of these patients become depressed subsequently. They develop anxiety at a later point in time. They develop problems with work-related issues because they can't function at work very well because they're scared of going to work and having a seizure in front of all of their colleagues. And for example, if somebody has epilepsy in this room and they're scared of actually having a seizure right in the middle of the room, what would they do? Most likely they won't come for a conference like this. You avoid a conference because you don't want to kind of make a public spectacle of yourself. And then you start kind of backing off. And obviously, if you start missing too many of these conferences and you're a partner, so let's say at Thomson Rogers, then your partnership is going to get impacted at some level, right? Because you're never there for any of your meetings, right? So then you already develop work-related issues, and that then actually leads to depression and the anxieties and everything else that goes on with it. It's more common in males more than females, and increased in patients with moderate to severe ABI. What about personality disorders? Personality disorders are a funny condition because you'd never know whether somebody has a personality disorder until you get to know them for a period of time. I've seen too many people being diagnosed as having a personality disorder after 10 minutes of meeting that person. I can't, right? Okay, you might get a very strong impression that there's a personality problem, but you can't diagnose a personality disorder, right? A personality disorder is a longitudinal diagnosis. You need to know a person for a period of time. You need to know what exactly kind of they do in certain situations and their maladaptive way of doing things. And then you might turn around and say these people might have a borderline personality disorder or an antisocial personality disorder or not. But a lot of these personality disorders also existed before the injury because that's what leads to the injury in the first place. If you're antisocial to start off with, let's assume that you're abusing substances, you're involved in a bar fight, and somebody hits you on the head with with a whiskey bottle or something, that's how you end up with a brain injury. So, but you had an antisocial personality disorder to start off with. Unfortunately, personality disorders don't get better after a brain injury, it gets worse, right? So, and one way of thinking about all of the things that actually happen after a brain injury is to think of it as exacerbation of who you are before the injury. For example, most healthcare providers, and most of us in this room most likely, are slightly obsessive to start off with, right? Otherwise, we don't get to this position. I mean, of being in this place. I certainly am. I mean, like people think that I'm slightly compulsive about a lot of things. So if I have a brain injury, the chances are that I'm going to end up with a full-blown OCD, right? And I know that, and I think it's going to be a major problem, right? So that's what happens. So if somebody is slightly anxious to start off with, the anxiety might actually be a very beneficial thing for them because it makes them gung-ho about their work. They write wonderful reports because they kind of read it through 3 times because to make sure that they know typos at all. That's fine. But when you get an anxiety disorder, you actually never read it at all because you're so worried about what that report is going to contain that you never even get to read it. That's the difference. So there's compensatory anxiety where we actually end up kind of reading through it and making sure everything is fine. And then there's an anxiety disorder where you don't read it at all, right? And most of us actually probably read our reports 2 or 3 times. But if we develop an anxiety disorder, we're not going to read it at all, and then I think we won't be kind of here. So personality disorders, most common ones are borderline and avoidant. And there's pseudo-depressed and pseudo-psychopathic personalities, and again, increased in patients with premorbid maladaptive personality. What about psychotic disorders? Again, I mentioned earlier on that there is a difference between psychotic symptoms after an ABI and schizophrenia. And the difference is that patients often in ABI, they're present with fragmented delusion. They don't have a well-formed delusion. Schizophrenics might come and tell you that they are from Mars, that they are kind of, that this is how Martians dress, that this is what Mars looks like, and all of that. Whereas patients with brain injury might say, I just get the feeling that I'm being followed by somebody. Right? So it's unformed, vague, but it's still there, but it still makes them paranoid and anxious. It's usually increased in the early post-ABI period, but this also might be because they might be delirious in the post-ABI period. And delirium by itself can also lead to psychosis. And increase in patients with diffuse cerebral swelling and midline shifts. What about attention disorders? It's also called secondary ADHD, post-TBI, and it's described in children. There's no research available in adults, but I see this every day. I see it in adults, right? Its incidence is between 16 to 20%, so that's 1 in 5 kids with a brain injury actually has an attentional problem. That's a lot of people, right? And mainly inattentive, rarely hyperactive. And pre-injury risk factors poorly understood, and there's no definite relationship of secondary ADHD to injury severity. Mild TBI, there's been some thought actually increases the risk as opposed to kind of severe TBI. And again, there's various parts of the brain are kind of implicated in this, like putamen, basal ganglia, thalamus, orbitofrontal cortex, etc. And again, it's comorbid with personality changes due to the TBI, oppositional defiant disorder, conduct disorders, or disruptive behavior disorders. And it's not associated with new onset depressive anxiety disorders. Is ADHD a factor? As I mentioned, it occurs in about 16 to 20% of patients, but inattentiveness and attentional disorder occurs in a vastly greater percentage of patients, possibly due to the apathy and anhedonia of the ABI itself. Neuropsychiatric syndromes causing or exacerbating attention disorder, like patients who have personality change, patients who are depressed, patients who are anxious, patients who are psychotic, patients who use substances, pain syndromes, all of this can also cause inattention. So just because somebody is inattentive post-injury doesn't necessarily mean they have an ADHD. You have to try and rule out all these other things, right? So what does all of this mean? Oh, and one other thing is iatrogenic syndromes. When I talk about iatrogenic syndromes, what am I talking about? Essentially medications. So medications are good things, but they're also bad things because they create their own set of problems. And if you don't understand those problems, then sometimes you sit and think that I'm giving this for this particular issue, but I'm developing this now. Is this a new problem that's developing, or is this a side effect of the medication? I'm actually going to talk about one of my failures later on today in terms of medications as well. So it's a very complex patient, and I'll talk to you about the patient. And that'll tell you how difficult it is to try and kind of understand some of these patients. What about sleep disorders? 46% of traumatic brain injury patients have a sleep disorder. And it's lately people begin to think about sleep disorders, but 10 years ago, hardly anybody thought about sleep disorders. People didn't think that sleep apnea was a major issue in some patients with brain injuries. Even now, I'm still having problems and fights with insurance companies for funding for CPAP machines. They will turn around and say, no, this is not because of the brain injury. This is actually because this person had sleep apnea from even before the injury. How do we know? I mean, this person never was on a CPAP machine, didn't have a sleep study. But only after the injury is this person having this level of fatigue. So just looking at timelines, one could argue that the brain injury actually had a major impact on this person's sleep problems, right? If a person isn't sleeping all the time, or not sleeping well, every aspect of one's life is going to get affected. I mean, in any one of us, I can become psychotic if I don't get enough sleep. And sometimes I do think that I am psychotic anyway, so it's all right, because I end up not getting enough sleep. So, but you end up with significant insomnia issues. And when I talk about psychotic, me becoming psychotic, I don't mean that I'm developing delusions, but it's this sense of losing touch with reality. It's the sense of kind of always feeling so fatigued that you don't know whether you are kind of fully there or whether half of your mind is somewhere else, right? That's this kind of slight, almost like a depersonalization syndrome that can happen. I mean, that's not full-blown psychosis. So when I talk about psychosis, I don't necessarily mean that I'm developing hallucinations and delusions and thinking that I'm from Venus or something like that. But it's this kind of almost half your brain, you have left it somewhere else, right? Patients develop narcolepsy. Narcolepsy is just falling asleep. So, I mean, you're here, I crack a joke, next thing you know, you're falling asleep. Okay, I don't have to crack a joke for you guys to fall asleep, but that's a different story altogether. But that's narcolepsy. But if that's happening all the time, how do you function in the workplace? How do you function in the community if you're falling asleep all over the place? I mean, and emotion can trigger narcolepsy. And I can go through a day, and most of us can go through a day, and we are going to get emotional at least a few times in that one day. I don't think anybody here is going to go through a day without having either laughter or sadness or something happening because somebody's talking to you about something, right? Some people develop something called leg movements in sleep where they're twitching with their legs. And this often is noted by partners because partners get kicked, right? So, but most of these, 1 in 4 people end up with excessive daytime sleepiness. And so they're fatigued all the time. And obstructive sleep apnea was more common in obese subjects. I mean, that we know, but I've also had obstructive sleep apnea in patients who actually are not obese after a head injury. Maybe because they ended up with some neck issues, right? Patients who develop kind of muscular weaknesses, people who are hemiplegic, they can actually develop obstructive sleep apnea as well. So there's no relationship between the presence of a sleep disorder and injury severity, cause of injury, or the presence of positive CT scan findings. We have to consider other psychotic diagnoses as well because, again, depression can cause sleep disorders, anxiety can cause sleep disorders, psychosis can cause sleep disorders, ADHD can cause sleep disorders. All of this can cause sleep disorders. So don't kind of jump in and say this person has a primary sleep disorder, whereas it could be just a secondary effect of another disorder as well. Medications can cause sleep disorders. Early post-injury patients had difficulty initiating maintaining sleep, whereas late post-injury patients had a preponderance of excessive somnolence during the day. Aggression. 35 to 96% of patients are aggressive immediate post-injury. That's a lot of people who are aggressive. It can happen less than 2 weeks to 4 to 6 weeks, and post-traumatic amnesia plus excessive behavior such as aggression, disinhibition, or emotional lability. I see a lot of emergency visits where they turn around and say this person is combative, right? Especially if their GCS is very low or if they're kind of, there might be substance use involved as well in the time of the injury. All of these patients become combative. So there's a lot of aggression right after the injury as well. And can also occur as a long-term sequelae after the acute recovery, days, weeks, months, or years later. So you can get damage to various parts of the brain and they can lead to all sorts of problems. You can get problems with hypothalamus, the limbic system, the temporal cortex, and the frontal neocortex. And you can get problems with norepinephrine, serotonin, dopamine, and acetylcholine. These are the 4 main neurochemicals. So when we use medications, we're trying to address the various areas of the brain, and we are trying to address these various neurochemicals. That's why medications become important. I don't know of too many therapies per se that would address all of these neurochemicals. So we do need to kind of modify or modulate these neurochemicals, and then the therapy is effective. But again, let me be very clear. Psychopharmacology is part of a whole. It's not the only treatment. It is just one part of a treatment. You need every other treatment. You need the therapies. You need the speech and language. You need the occupational therapy. You need the cognitive behavior therapy. You need all of that to make this person whole again. You cannot do that just with medication. And I'll kind of explain that in a little bit. So what about the features of aggression in ABI? It can be reactive, non-reactive. Non-reactive means, there's no trigger, but the patient still get aggressive. Non-purposeful, explosive, and periodic. So it happens every so often. And what are the behavioral syndromes? And these are the 3 main behavioral syndromes. If you can understand the behavioral syndromes, then it's easier to try and figure out what direction we have to try and go and treat them. So you get behavioral excess, like impulsivity, hyperactivity, lability, psychomotor hyperactivity, and aggression. And so this is the impulsive, aggressive group. And the damage is the orbitofrontal area of the brain, just at the bottom of the brain there, in the front area. What about the dorsolateral frontal syndromes? It's a slow syndrome. These are the patients who become apathetic and abulic. The inattentive, the poor judgment, perseveration, the psychomotor retardation, the passivity, these are the people who present often as very depressed. And here the damage is more lateral. Then you get the ventromedial frontal syndrome. This is where the damage is more interior, and you get apathy or the poor initiation. Sometimes apathy is more problematic than aggression. And this is often described by spouses. Spouses are okay if somebody becomes hyperactive and they actually want to still go out and mow the lawn. They have a lot more problem when somebody sits in a corner and doesn't want to do a thing, right? They get very irritated. They sit and think this person is just doing nothing, right? And that seems to kind of hit all of their nerve endings, right? And spouses will come and tell me, I wish that this person will start moving, right? So I have to now try and give stimulant just to kind of get the person moving so at least the spouses will calm down, right? So I'm not sure who I'm treating, whether the patient or the spouse, but anyway. So the management, psychopharmacology management by itself is generally futile. It needs to be part of a team approach. Patient is at the center of coordinated care and it needs to be individualized. Why? So ABI, we know about psychotic diagnosis. We know about the medical issues that might happen. What about the cognitive deficit and the medications? So these are 4 things, right? This is not the only thing that happens after an ABI. You get substance abuse and dependence. You get financial issues. You get work issues. You get family issues. You get premorbid factors. You get compensation issues. You get psychosocial issues. And if you don't treat all of these things, you're not going to make the person better, because you can't just treat the 4 things on the left side and there's 1, 2, 3, 4, 5, 6, 7 things on the right side and expect the person to get better. Just balancing things out is not going to work, right? And if somebody is not depressed but has no money to live on, how successful do you think you're going to be in giving them antidepressants? Or if somebody has got extreme anxiety but has no work, giving them an anxiolytic and then kind of not doing something about the work, is that going to work? I don't think so, right? So that's why you need the help. I am not an expert in all of these other things. I don't claim to be, I don't have the time for it, and so I need help in somebody to go into a workplace and do a work assessment to see whether this person is able to return to work, that particular type of work that the person was doing before. Look at their finances. Can we apply for CPP? Can we apply for ODSP? Is there some sort of other insurance payments that this person is eligible for? Is there some sort of family issues that we need to deal with? Is the spouse depressed? Is the children kind of having problems at school? If you're a parent and you've had a brain injury and now you see that your son or your daughter, who is maybe, let's say, 12 years old, is is struggling at school, and nobody's really paying any attention to that, but everybody's kind of trying to make you feel better, do you think you're going to be very successful in improving that person? No, you're going to be successful if you can try and get some help for that kid, maybe get a tutor or somebody like that to try and come in and maybe help the kid kind of do better in math, right? So sometimes psychopharmacology is a 3rd line of treatment. There's 2 other things that needs to be done first. Sometimes it's the first line of treatment. The trick here is to figure out what the sequence of approach is. What needs to be done first, what needs to be done second, what needs to be done third. So initial management, so first of all, you need to understand this patient. The reason I went through all of this is to try and tell you that how important it is to try and understand the patient. If you don't understand the patient, don't know where the patient is coming from, don't know what the patient's background is, don't know the family of origin, don't know the cultural background, it's very difficult to know in what direction you're going to go in. So that's why it becomes absolutely imperative for you to know all these things. So spend time. I spend generally 3 sessions assessing a patient. I very rarely can do a consultation in a full brain injury patient in 45 minutes. I just can't, right? I've been doing this for a long time. I still can't do a 45-minute assessment. So I think, when I teach my residents, they sit and wonder, but you're trained to do a 45-minute assessment. Yeah, I tell them, yeah, but my training was a long time ago, right? So now I need a lot more time, right? Because I have to talk to the patient. I have to talk to the patient's spouse or caregiver. I have to talk to whoever else who might be interested. I have to look at the amounts of data that come in, right? And if you can know all these things and understand who this person is, then you're in a much better position to know what direction you're going. Again, assessment is also dynamic. Your assessment is not just the first time. The first time you see the patient, you'll get one particular impression. The fifth time you see the person, you're going to get a totally different impression, right? So then you have to be able to modify that impression that you have and modify your treatment accordingly. So assess, do a thorough case review, do a current and past level of functioning, look at their competency as well. I've had patients who are glaringly not competent, but we are listening to the patient giving us instructions. I mean, it's ridiculous. The patient says no, but the patient is kind of psychotic beyond belief and is kind of thinking that he's hanging from the ceiling. And we actually getting instruction from that patient. No, let's make the person not competent. Let's get a substitute decision maker involved. Let's actually get some proper treatment to that patient. Look at the daily living skills. Look at their cognitive ability. Look at their social skills. Look at behavioral issues, family and social relationships, recreational activities. I've had patients where I've actually kind of stopped all treatment. The only treatment that they have received in the summer is a season's pass to Wonderland. That's the only treatment they need for that summer, right? Because they have therapied out. They have had 5 people coming in every week for the last year. They haven't had a break. They haven't had a vacation, right? This is an 18-year-old girl, right? I would be burnt out. I would actually be depressed just about the treatment I'm getting, right? So we kind of cut back everything for the summer, gave the person a month off, like getting a vacation, managed to get the insurance company to pay for a Metropass, actually a Metropass as well because they need to travel, but get a season's pass for Wonderland or something like that, and the person was much happier at the end of that end of that month or 2 months. And then you restart the treatment. I'm not saying don't give the treatment, but give the person a break as well. So sometimes the best treatment is no treatment, right? So follow-up, then you have to deal with aggression and agitation. Teach alternate behaviors. Develop contingencies and the medication. Deal with disinhibition and sexually inappropriate behaviors. Deal with passivity, attentional disorders, memory deficits, various psychiatric syndrome. Deal with the patient and family. Deal with the finances and housing. Now, we get to the crux of the matter, the medications. So what are the common medications that we use? First and foremost, antidepressants. They are broad, they're used for a lot of conditions other than depression, and they are relatively well tolerated without too many side effects. And SSRI is selective serotonin reuptake inhibitor. So again, as I mentioned in a previous slide, one of the neurochemicals that's affected is serotonin. SNRI is serotonin and norepinephrine. So you're addressing 2 neurochemicals. Then there is the REMA, which is a reversible MAO inhibitor, which is addressing a different pathway altogether. And then there is the older one, which is the tricyclics. Anxiolytics, we use benzodiazepines. Again, a lot of people will turn around and say, don't use benzodiazepines in patients with brain injuries, especially if they've got a sleep problem. But the problem that I have sometimes with patients' anxiety is so bad that I have to use benzodiazepine because nothing else settles them down. So you can use benzodiazepine, but judiciously as long as you know what you're doing and you can monitor it. Everybody worries about addiction. But my logic is, are you worried if you're diabetic and you're on insulin about getting addicted to insulin? You're not. It's a treatment, right? So benzodiazepines can be a treatment. So why are you so worried about an addiction? It's something that we are monitoring, something that I'm controlling, that we are not kind of giving indiscriminate doses of it, but it's given as a specific treatment. So addiction is not an issue, right? There are even people who get prescribed, especially in an institution, 1 beer a day or something like that. That's not an addiction. So it's actually a treatment. It's a treatment for that person because this person is quality of life. It's better because they get that 1 beer or whatever, right? Neuroleptics. Again, I use quite a bit of the neuroleptics. Things like olanzapine, risperidone. There's newer ones like Invega, Abilify, Latuda. All of these you can use and at various doses. Sedative hypnotics like Zopiclone for sleep. There's a new one which can also be used that works for much shorter periods of time. And anticonvulsants. Anticonvulsants are used not just for seizures, but it's also used for behavioral control, mood control, right? Things like carbamazepine, valproate, they are used actually as behavioral control for stabilizing mood. It's not used always as anticonvulsants. So some of my patients are on Epival, not because they've ever had seizures, but because that's the only way that I know of to control that behavior, right? And stimulants like Ritalin, Concerta, Dexedrine, just to see whether we can get them out of that abulic syndrome or the apathetic syndrome that I talked about earlier. And most of these medications, unfortunately, can't be given alone. It's ineffective. It needs combinations. I haven't had any success in giving a patient single antidepressant and that patient has ever got better. It's never worked in all these years. Generally, I had to give a little bit of an antidepressant, give a little bit of an antipsychotic, give a little bit of a sedative, right? 2 or 3 medications in smaller doses. Now, if you give an antidepressant, you might have to give higher doses to achieve the same effect, but then this person is going to have side effects. It's much better to give moderate doses, but give 2 different medications so the person doesn't have side effects or has minimal side effects. So what are the common side effects that we're looking at? It depends on the group of medication, dose of medications, route of administration, patient profile, drug interactions, and unknown factors, idiosyncratic reactions. But we are looking at something called acute dystonic reaction with neuroleptics. Acute dystonic reaction it's a medical emergency. It only happens very rarely. It's happened to me once in all these years. And I had to give that person kind of intramuscular injections of another medication to kind of get that person out. But it's extremely uncommon. And I've got thousands of patients on this. But it's where they suddenly stiffen up and they can actually end up with laryngospasm. But it's an extreme uncommon, but it needs to be known because if somebody starts complaining of muscle stiffness, it can be an extrapyramidal symptom. It doesn't have to be at the degree of an acute dystonic reaction, but it can actually at the degree of EPS. Akathisia is an inner sense of restlessness. A lot of patients develop akathisia. They're already restless to start off with. They actually become even more restless as time passes. So medications can lead to akathisia. Not just neuroleptics. Patients who are on antidepressants can develop akathisia. And that's something that people don't often realize. Patients on Prozac can develop akathisia. Patients on FXO can develop akathisia. So somebody you have given an antidepressant to, and after some time they seem to be even more irritable to start off with. They may not be depressed, but they're more irritable. It might actually be a side effect of the antidepressant that you're giving them, right? Tardive dyskinesia is a long-term side effect of neuroleptics, which is kind of a movement disorder that develops of their hands and of their face and everything else. There's something called a bonbon syndrome. Bonbon syndrome is where they start poking their tongue into their cheek, so it's almost like having a candy in their mouth. So if you start seeing that, the only treatment available is basically taking them off the neuroleptic. You can get GI upset, insomnia, hypersomnia, postural instability, and fall. But again, most of these are early onset side effects. They happen for the first week or so of initiating medications and then usually settle down. They actually get better. Some of them actually develop incontinence. And incontinence is a problem because often patients are incontinent to start off with. So as part of their brain injury itself. So you need to actually be a little bit careful with that because incontinence can get worse. And a lot of these patients, especially if they're on antidepressant, can develop sexual dysfunction. A lot of my patients, I have problem with giving antidepressants because they develop sexual dysfunction. And most brain injuries occur, in young people. So if you're 25 years old and you don't have any physical limitation, want to get back into a normal life, and that includes sexual activity, and now you kind of have sexual dysfunction as a result of an antidepressant, how long do you think you're going to be compliant? Right? So you kind of try and find medications that don't have that side effect, but there's only, unfortunately, 2 of them, Wellbutrin and Remeron, but neither of those medications are always the best anyway, so it becomes a bit of a fine balance. Stimulants can cause akathisia again, irritability and aggression, so you need to be careful with that. And stimulants can be abused, so you need to be a little bit careful. Acute aggression is often treated with antipsychotics to start off with. Atypical antipsychotics like risperidone, olanzapine, and higher doses, 20 milligrams per day of olanzapine, or risperidone up to 6 milligrams per day. As I mentioned earlier on, I'm talking about medications, and I think I'm beginning to see a lot of glazed looks. So that's why I kind of talked about all these other things anyway. Benzodiazepines, clonazepam, right? Chronic aggression, again, you think about anticonvulsants, lithium, right, which often is used for bipolar affective disorders, buspirone, which is also used for movement disorders, beta blockers. I mean, I often use propranolol, which is actually an antihypertensive. And it actually calms people down. It's people often use it just before giving a speech. Actually, I should have used some this morning, but anyway. But propranolol is often people take it because they have stage fright. A small dose, and it actually calms them down. So often you can actually give it in patients who also have anxiety, and it actually relaxes them a little bit without some of the side effects of sexual dysfunction that an antidepressant will cause. Antidepressants, anxiolytic, and antipsychotics. Okay, I'm going to talk briefly about a case. This is Shane. He is 45 years old. He's a former black belt in karate, right? His motor vehicle accident was about more than 20 years ago. He had a severe ABI. I'm not going to go into what the ABI is, but he had a severe ABI, and he is completely aphasic. That means he has both difficulty in understanding language and expressing language. So he can't tell you what's wrong with him, right? And you haven't got a clue what's going on with him, right? So he can't communicate what he wants or needs. In addition, he is diabetic, and he's a brittle diabetic. That means his blood sugars go all over the place, right, very easily. So you give a little bit of an insulin, his blood sugar can drop down to 2. You give a little bit of sugar, and his blood sugar shoots up to 25, right? Again, the reason I say that is that diabetics and various changes in blood sugars can also lead to aggression, right, and anxiety and apathy and fatigue. So you have to also realize that it's not just the psychiatric condition that often leads to a lot of these issues, but medical conditions as well. This gentleman has severe behavioral issues, especially during care routine. So if somebody wants to kind of touch him to kind of give him a shower, and you have to realize that this person is also incontinent of urine and feces, right? So they want to give him a shower. Every time you give him a shower, you need about 4 people to hold him down, because otherwise he can actually punch you. And this guy has ripped toilets out of concrete floors and thrown it at people. So he's quite, and he, as I said, he's a former black belt in karate. I don't know what dan he was, but if he hits you, it's going to hurt, right? So you try very hard not to let him hit you, right? And another thing with him is that he can tolerate medications, doses of medication that will flatten an elephant, right? If I'm on the medication that he's on, I basically will be in a coma for the next 6 months. And these are the medications that I've given him, right? I'll show you the list of medications that are given, and you're going to be sitting and saying that Dr. Seyone doesn't know what he's doing, right? Because he's on humongous doses of medication, because he's so resistant to it. I mean, nothing that we do seems to touch him very easily, right? How do you do a behavioral program in somebody who can't tell you what's happening? Right? So behavioral programs is a little bit of an issue here, because you really can't do any cognitive work with this guy. Even behavioral program, I mean, if he's going to punch you, first of all, I mean, how many people are willing to actually do a behavioral program with this person? Get anywhere close to him? I mean, you try to do things with the 10-foot pole, but I mean, that doesn't really, not very kind or compassionate way of doing treatment. So you try and get close to him, but you really can't do too much of a behavioral program. He's in a locked institution, but in the community. Before that, for about 10 years, actually, he was in a hospital setting, but he was in a padded room. That's what they did. He spent 90% of his time in a padded room in a hospital. So he could pound on the walls as much as he wanted, and nothing would happen. I mean, he can't hurt himself because there was nothing else in the room other than just padded walls, right? So we took him from the hospital, and I've been working with him for about 10 years. We took him from the hospital. He's in this unit actually up in Oakville. Everybody knows probably which unit it is. And his quality of life has got better. He actually goes out, accompanied usually by 2 staff. He has gone to Tim Hortons. He'll come and sit in the great room and kind of just observe things. So his quality of life, I mean, he's still doing very little, but his quality of life is a lot better than where it was, where he was in a padded room, right? So his current medication list is this. That's page 1, right? So as I mentioned, he used carbamazepine. I remember telling you that carbamazepine is also used for mood control and behavioral control. He's on 1,200 milligrams of carbamazepine. He's on Seroquel, he's on 800 milligrams. At one time, he was on 2,400 milligrams of Seroquel, right? He's on Zyprexa, which is at 1530 milligrams. He's on diazepam, which is a benzodiazepine at 30 milligrams. He's on various types of insulin, both Humalog and Lantus. He's on benztropine, which is to manage side effects of akathisia. He's on 4 milligrams of that. He's on Tecta for stomach problems. He's on Altroxin for thyroid issues. He's on Abilify. Actually, he's not on Abilify. I just took him off a few days ago. He's on various other multivitamins. So if you think about it from a psychiatric medication, it's huge doses of medications. As I said, this will knock down an elephant, all right? I'm looking at Dr. Narkut, and he's kind of looking, having this shocked look on his face, right? You have to realize that we got here not immediately. We got here over the 10 years. We got here by starting him on 5 milligrams or 7.5 milligrams of olanzapine and working our way up to 30 milligrams. We got here by giving multiple medications. But he needs these medications to function, to give him that quality of life, rather than leaving him in a locked unit, right? Because it's very easy to turn around and say, I'm not going to give him all these medications because there might be some long-term tardive dyskinesia issues. Yeah, but my worry is that what is he going to do for the next 10 years, because I'm worried about him developing tardive dyskinesia 10 years from now. If he develops movement disorders 10 years from now, yeah, at that time I'll maybe take him off some of these medications. At that time he's going to be 10 years older. Maybe he's going to be a little bit weaker. Maybe he won't actually punch people as much, right? Maybe people won't be as fearful about him coming and sitting in the great room, because right now he is 45 years old. He is, 5'10", about 180 pounds, and he's pretty muscular still. It's very difficult to kind of manage him when he gets angry, upset, right? And also he uses, I can't say he uses, but he becomes fecally incontinent every time he actually gets upset. So he actually you'll take him to the toilet, put him there, he won't go, he'll get up, put his trousers on, and he'll then kind of go, right? And then you have to then take him for a shower. And that's when a lot of the care routines and all the kind of aggression start. So you try and avoid some of those by trying to kind of manage the medications. That's his page 2 of medications. Right, but these are, if you notice, these are all PRNs. So he's on diazepam as a PRN. PRN is basically as needed if he becomes aggressive. So he can get up to, another 20 milligrams of diazepam. He's already on 30 milligrams. He can get another 20 milligrams of diazepam on a regular basis. He's on lorazepam. He's on a few other kind of analgesics and stuff. And one of the things that I want to kind of emphasize to you is whenever you give medications, you have to make sure that you keep adequate data. If you don't keep adequate data and you don't know what is happening and what the medications are doing, it becomes a pointless exercise. So I've known of people who get prescribed medications for 3 months, they haven't got a clue what's happening to the patient. What's the point, right? I tell my patients, and the people who come with the patients, let me know, if there's a problem, let me know 2 weeks from now as to how this person is doing. Why do you want to wait 3 months? What's the point? You're wasting your time, and basically, not my time, but you're wasting your time because for 3 months you haven't got better, right? It might be better for you to let me know. All it takes is a phone call. I don't expect you to come and see me every 2 weeks, but you can phone me up and say, okay, the medications are working well. I had a minor side effect for the first couple of days, but that's gone away. But what we gave the medication for seems to be helping, right? Or not helping, right? So if you notice here that we start off in November 2002, when I first started seeing him, he was on a whole bunch of pills. And we kind of keep data as to, okay, we discontinued the Prozac that he was. He was on 10 milligrams of Prozac, which is kind of a placebo dose in somebody like him, right? And then if you look at in 2005, then we actually kind of made a number of other changes, like things like we discontinued lisinopril, we put him on Seroquel, we decreased the Seroquel. FXO, we discontinued it. We kind of, number of changes. So we actually kind of, what I'm trying to get at is, again, remember I mentioned that this is dynamic. So you can't get complacent. You can't kind of give a medication and think that this is going to work for the next 6 years. It never does. Since I started doing this job, I've realized that I believe in full moon. I believe in every kind of cultural idiosyncrasy, because I have patients who decompensate for no reason that I can identify. Nothing has changed. Absolutely nothing. But all hell breaks loose out of the blue, right? So you need to keep working with the patient. Like this particular patient right now is not doing so well. He actually was stable for the longest of time. For the last year, couple of years, he was actually fine. He was actually coming and listening in the great room. Last month, he's actually become more aggressive and more out of control. And I have no idea why. Nothing has changed, right? So we are actually kind of, again, modifying medication. But you have to realize that when you touch one medication, everything else goes wrong. So you have to then kind of start messing around with everything else as well. So these are the type of data we keep. So we have to keep data looking at what are the PR and agitation, what are the kind of the levels of agitation. I mean, they call it AG1, AG2, which is kind of just the degree of agitation. So we can see over a period of different medications at the bottom, you can see that things are actually getting better. Its number of agitations are going down. So you know you're on the right track, right? Here again, you look, sorry, I put a different background. The background didn't come in, actually. But again, this is a weekly way. I mean, this is almost like a daily way of looking at it. So it shows you what the trends are, what you're trying to do. Again, different levels of agitation and amount of PRNs given for this patient. Same thing, I mean, this is agitation too. These are higher levels of agitation. What I'm trying to get at is that if you don't actually keep this data and know that all these are happening, then you're wasting your time because you have nothing to you have no information on which to kind of make any changes. So you have to keep this data. That means that the staff who you have in the front lines have to be able to collect the data. And that means that you need to be able to tell them what data you want collected. Right. If you can't tell them that and they can't do it, then basically you're kind of in a little bit of a tough situation there. The same thing, it's kind of average of physical aggression. I mean, as you can see, things actually get a little bit better, then there's peaks. And sometimes when you have these little bit of peaks, you can understand what crossed that peak. Maybe there was a medical issue at that time. Maybe his diabetes was a little bit out of control. So if you plot everything on a graph, you can actually make some sort of a reasonable guess as to what is going on. Looking at numbers, you can never make an idea as to what's going on. I mean, so I've seen pages on numbers, and it doesn't mean anything to me. I mean, I can't get trends from numbers, right? So that's why I ask people to kind of plot things for me. Things like bedroom seclusion, right? This is, again, this has various other graphs, but I'm going to skip this. Easy, isn't it? Anyway, one other thing. Why did I put this on? I actually want everybody to understand a little bit about what stress is. Right? Because stress is what every caregiver experiences. It doesn't matter who that person is. It doesn't matter whether it's family. It doesn't matter whether it's friend. It doesn't matter whether it's a personal support worker. It doesn't matter whether it's one of the staff members here. All of us feel stress, right? So we might have more headaches, muscle tension, stomach ulcers, faster heartbeat, or emotional things like we might actually start worrying a little bit too much, become moody, we don't enjoy our vacations as much. And all of this then leads to various psychopathologies within caregivers. And you have to address this as well. So not only are you treating psychopharmacologically the patient, but you also have to treat the caregiver, because caregivers are the primary people who are providing support to that patient. If that caregiver isn't there, who is actually going to provide support to that patient? And also, you need to kind of look after the caregivers as well. But just to be selfish, there's nobody else. Often, I mean, the medical system is such that there's no institutions now where you can actually put them there and forget about them. Usually, the patients are living with family members. Now, if the family members get burnt out, who is there to look after these people? So we have to look after the family members as well. Looking after the look-afters, right? So look for psychopathology in caregivers and help them as well. Now, just to kind of wind up, behavior therapy to identify triggers and modify responses are necessary. Cognitive therapy, the problem with cognitive therapy is only kind of, it's useful in people who have some level of cognition. In patients who have got severe brain injury, it's often more difficult to do that. So it becomes more behavior therapy and supportive and individual therapy. I think that's enough for today. Thank you.
Thank you, Dr. Seyone. If there's anyone who has any questions, please step up to the microphones. No questions? You covered everything so carefully, there's no questions.
Yes. Yes. Well, it depends.
What about, you were talking about medication, like the kind. What about actually exterior environmental concerns, whether it be actually the staff members or things that happen in his world, or in the community or the news that could affect his behavior?
The question is, how do you respond to environmental stimulation of a patient that might actually trigger a patient? Am I right? Right. I can't control the environment. You can't control what's happening in the news. You can't control what's happening there. Only thing that you have any type of control or kind of help over is the patient. So sometimes in that situation, what I will try and do is try and make the patient respond less to that environment. So give them something where you're basically cocooning them a little bit in kind of a little bit of soft cotton wool in a sense, but with medications. If I can do that effectively, then the persons can still respond to the environment but not get aggressive about it. Might become, let's say, emotional about it because he or she hears about the kid getting hurt. That's fine, that's normal response. But as long as it doesn't get angry and wants to kind of pick up a hatchet and go and kind of after somebody. Yeah, so in that situation, I mean, a little bit of like a small dose of an antidepressant or an antipsychotic or a combination might actually help because it prevents that response, prevents that person from going from that 1 all the way to 100. All of us go from 1 to 20, that's fine. But if I can keep it down to less than 50, then I'm happy because the person isn't overreacting. Yes?
Can you comment on the use of melatonin for sleep difficulties, mild sleep difficulties with ABI?
Sure. Melatonin is often used, as you know, in patients who have delayed sleep phase syndrome, jet lag. Those are the two main conditions for it. But in patients who have sleep disorders, I've used it, but not very often. Because most of my patients who have sleep disorders have significant or severe insomnia, who have sleep apnea, who have periodic leg movements in sleep, or some of these kind of more definitive sleep pathologies where melatonin isn't going to do anything, right? So in those patients, giving melatonin is a little bit of an underkill in a sense. So it's kind of helpful in somebody who has a jet lag, who basically needs a small dose of melatonin to get their rhythm back on track. But in somebody who has anything more severe than that, you need to give them a little bit more of a stronger tranquilizer, as it were. So if they've got insomnia, give them Zopiclone or Stanox or something like that. Or if they've got sleep apnea, get that treated. Or if they've got leg movements in sleep, give them Requip or Mirapex or something along those lines. So melatonin, I know a lot of people end up taking melatonin, but I'm never certain as to how effective it is because the severity of the sleep problem is a little bit more than what one might actually anticipate whether melatonin is going to be helpful. Yes?
Hi. Can you comment on treating conversion disorder? I'm sorry. That seems to be the common response.
The question is, I mean, you asked me the question is, how do I treat conversion disorder? The question is, I mean, do you actually ever treat conversion disorders? You can identify a conversion disorder. I'm never sure whether you can treat it, right? I have a patient right now. I think somebody knows about that patient as well. Young lady who's, I think, probably late teens. I mean, she's, I think, 18 or 19, had a relative, maybe, let's say, a moderate brain injury. She is almost in a fugue state, complete fugue state. I mean, like, comes there, doesn't say a word, that looks, parents usually bring her holding her hand. I mean, is kind of completely out of it. I mean, we don't know whether she's coming or going. I mean, what's happening to her? Is this conversion disorder? We don't know because she's not telling you anything. I mean, you really can't talk to her to find out whether there is any triggers. One could argue this could be a conversion disorder. One could also argue that this could be malingering. One could argue that this could be something else because there's no neurological basis that we know of for this person to have this fugue state, right? I've had other patients who have got conversion disorders who, again, when people develop a conversion disorder, by definition, there has to be some sort of emotional crisis that basically led to it. But again, by definition, it's almost impossible to identify what that crisis is because people, if you know what the crisis is, then basically the person won't have a conversion disorder in the first place, right? So often you know that this is a diagnosis, but there's no effective treatment for it. Sometimes, like in my patient, I'm actually thinking of doing two things. One is that we thought, let's try and stimulate this patient. Maybe there is some sort of apathetic syndrome going on. So we actually gave high doses of stimulants, didn't do a thing, right? We gave antidepressants and antipsychotic. Maybe we thought maybe she's in a psychotic meltdown, as it were, because she's not talking to you, so you don't know, right? So we gave her antipsychotics, didn't do a thing, right? So what's the next step? There's something called a sodium amytal interview, which is a very old treatment where you actually give sodium amytal, which is actually laughing gas or truth serum, as it were. You give a small dose of it, and it basically disinhibits them. So if you have a physiological reason for that, like for example, if you're paraplegic but it's more because of a emotional crisis, sometimes the paraplegia actually recovers while you're on that amytal, right? I've actually done that only once when I actually was a resident. We actually give sodium amytal to somebody who was paraplegic, and when that person was kind of in all this almost semi-sedated state, the person started moving their legs. As soon as the amytal wore off, they went back to being paraplegic, right? So that's the problem. So you, again, can identify that this person may have a conversion disorder. Sodium amytal is never a treatment for it, unfortunately, right? Two other treatments that I'm thinking of for my patient is basically doing something called ECT, right? Is this almost like a catatonic state because of depression? Right, 18-year-old, did she have some sort of an emotional crisis at around the time that all this happened? We don't know. So I'm thinking of whether I should even do ECT. That's kind of the last resort. But one step before that, I'm actually thinking of doing something called rapid transcranial magnetic stimulation, which is a non-invasive way of doing ECT. It's basically kind of identify where certain areas of the brain which might actually be causing depression and kind of sending pulses, magnetic pulses. It's actually being done at the hospital right now. And so that might be a non-invasive way of kind of stimulating them or doing an ECT without actually doing an ECT. If that doesn't work, then the ECT is the next option. So I don't have an answer for you. I mean, I don't have an easy treatment for this. It's basically often, and also one of the hallmarks of a conversion disorder is that the longer it lasts, the more entrenched it becomes. And after about the first year or two, basically you can't do anything about it, right? At least after about 2 years. First year, maybe you're lucky. So it's like sometimes you identify that this person might have a conversion disorder and say, okay, this is about as far as we can go, unfortunately. Yes, David.
For those of us who are hoping to benefit from your assessment, when we look at the piles of paper that we have in our offices and thinking about what can be of most use to you, I know it's difficult patient to patient, but what generally helps you best in following the patient to aid your assessment in terms of the history of information? I've got another question as well.
There isn't, I mean, I don't have a standard response because, I mean, to me, each person is different. And so I don't turn around and say, okay, give me this amount of information and then I'll kind of, that'll be enough. Because sometimes the information that I get is too much, sometimes the information I get isn't enough, right? So as I said, first and foremost, I need to see the patient. So that's to me the key because, I mean, I don't read through all the information that I get on my patient till I see my patient because I don't want to develop a bias internally before I see my patient. So I never read anything more than the name of the patient. Very rarely will I know, okay, this person even had a brain injury. So I assume that the person had a brain injury at some point in time. But I actually kind of do the assessment. At the end of the assessment, then I will sit and read through all the paperwork. So, I mean, getting a summary would be helpful. I mean, like if somebody can summarize kind of all of the various therapeutic reports, I mean, and say, okay, this is what has been tried and this has been helpful or it hasn't been helpful, might actually make it easier. And also kind of weeding out some of the more pertinent reports like neuropsychological testing, some of the CT scan, MRI reports, those are the type of thing might actually kind of make things a little bit easier rather than having to go through 5,000 pages to try and find one sheet, right? Did that answer your question?
Yes, thanks very much, Doctor. And I was just wondering if you, on reflection, look back on treatment of children versus adults with TBI and tell us if there are very significant differences in the way you do treat them.
The differences are that children are easier to treat at some level when they're younger, more difficult to treat when they're teenagers, because they're already going through kind of emotional crisis when they're teenagers. I also have a teenager, by the way, so I know what it's like right now. And when they have a brain injury, they become even more difficult. So it's much easier to actually kind of label them as having a personality disorder. So you have to be very careful that you actually don't label them as a personality disorders, because most teenagers, I think, when they are kind of 15 or 16, are borderline by nature. So it's like, don't label them. So, and also treatment of young kids is often actually not treating the kids themselves as much as treating the parents. Or not, actually treating is the wrong word, educating the parents, right? As to what it is that they need to do to make their kids a little bit better. So how do you maintain a structure? Because kids do well in a scaffolded environment. So that means that if you can, I mean, like, what's a scaffold? Scaffold is basically kind of I don't know whether anybody knows about this, bamboo scaffolds that they build around in Thailand and places like that, which actually hold the building up. It's basically, that's what kids need. They need that scaffolding. And the scaffolding is often given by parents, family members. And you have to teach them, how do you scaffold a kid without becoming intrusive, without suffocating the kid? Because that's what parents often do. And I probably will do the same thing. When your kid has an injury, you often become overprotective. So you never want to let that kid even get out of the house. Never want to let that kid even ride a bicycle. Forget about going to Wonderland, it ain't going to happen. Whether you're going to on a ride or not is beside the point, right? So sometimes educating the family and saying, no, this kid still needs to have a life. He still needs to go out with friends, still needs to do some things. Make sure the kid wears a helmet. Make sure kind of you do all those things. So I spend a lot of time trying to educate the family as to what is possible and what isn't possible in kids who have had brain injuries. And then you have to specifically treat conditions like attention deficit disorders more in kids than in adults, because described more in kids, actually. So these kids might require like stimulants, and also will require education in schools. So if you can get somebody to go to their schools and make some modifications to the classroom, such that they get more one-on-one help, or they get some educational support, that's probably going to kind of be carry through a longer way than giving medication to kids. Medication's going to play a secondary role in kids than in adults, but here you need a lot more of the work with the family and with the kids' environment.
All right, Dr. Seyone, thank you very much for your excellent presentation.
Thank you.